Should we start like exactly on time, or should we wait a couple minutes? What do you guys think? A couple minutes right now. So welcome. I'm Dr. Richardson. Thank you for coming out. A couple things I wanted to ask just before we started talking about trigger fingers and other things. How many of you heard about this from the newspaper ad? So let's see, keep your hands up. 1, 2, 3, 4, 5, 6. Okay. How many of you heard about it from Facebook or from social media? 1. Okay. That's okay. And then others, word of mouth, or?
I got it from my wife, and I don't know.
Just online. Okay. Can you keep your hands up for a second? Is that the rest of you? 1, 2, 3, 4, 5, 6, 7, 8, 9. Okay, so 6, 1, 9. And then Espire. Yeah, how many heard from the Espire?
Yeah.
So 1, 2, 3, 4. Okay. So a little overlap there. But mostly from the newspaper ad, it looks like. Okay. Nice. All right, well, thanks for coming again. What's that? I guess. We just, it's information we like. Oh, I need the... Can you hear me? Is that better? Okay. So, again, I'm Dr. Richardson. I've been here in Prescott for 9 years now. I did my medical school training at Ohio State University, so yeah, go Bucks. Residency in orthopedic surgery at Indiana University, and then I did a hand surgery fellowship, a hand and upper extremity fellowship at University of Rochester in New York. So lots of different places, none of them here. I did go to Arizona State as my undergraduate though, so Arizona boy, born and raised. My mother actually graduated from Prescott High School a long time ago, and married my dad. Met my dad at Arizona State as well, and then married. So those are my Arizona ties. That's why we came to Prescott. My wife and I have 4 kids. Came here after we finished. It was because of the family connection here. And there wasn't really an orthopedic trained hand surgeon at the time, so we thought, hey, this is a good place for us, and it's a growing community. Lots of hand issues. Back then, though, pickleball didn't really exist, did it? I mean, how long has it been now that pickleball's been a big sport? What, 5 years maybe? Maybe longer? I don't know, something like that. All right. Well, thanks for coming again. So we're going to talk a little bit about trigger fingers, and then some pickleball topics, and then whatever else you want to talk about. Yeah, I think we probably have, about an hour or so, something like that. After we're done, we've set up some ultrasounds in the back. So the nice thing, kind of the neat thing about what we're going to talk about trigger fingers is that we're doing a new procedure to correct trigger fingers, and we do it using an ultrasound machine. So the same machine that you would use to look at a baby or look at a vein or something like that, you can use to do a trigger finger as well. And so it's kind of neat. That's kind of why we're doing this, to let people know about that. Okay, can everyone hear me though? Yeah? Okay. Let me know if you can't hear in the back. Bring it closer. Probably don't need to do that either. Lower your eardrums out. Okay? So trigger finger, let's talk about that real fast and kind of see if I can get this. Okay? It worked. So the medical term for a trigger finger is tenosynovitis. So now you see why we call it a trigger finger, because it's not. It's a mouthful to say that. And basically what happens with that is there's narrowing of the sheath that goes around our tendons. So tendons are the things that move our fingers, right? Move our toes, move all of our body parts. They connect to muscles, and the muscle pulls the tendon like a little rope. The tendon attaches to the bone and moves the bone, okay? And so those in certain places, our fingers are no exception, have to pass through kind of thin or narrow passages. Sometimes those tendons swell, and that can be from any number of reasons. People often come into the office and say, Doc, why did I get a trigger finger? I say, well, what have you been doing lately? Well, I went out and I pulled 1,000 weeds, and I chopped a cord of wood, and I, all this stuff. And probably what happened was that person made their tendons swell because they were using their hand a lot. Because it was swollen, it gets caught as it goes through these little pulleys, or these little narrow areas, and it rubs on that pulley. And when that happens, it kind of becomes a self-perpetuating process where the tendon rubs on the pulley, it gets swollen because it's rubbing on it, and then the pulley actually swells and narrows because the tendon is rubbing on it, and it's hard to break that situation. Somebody I heard mention said, I talked to somebody that said it would go away. Sometimes it does. Sometimes it does. We really don't know probably as doctors how often trigger fingers will go away on their own, but sometimes they will. Often though, you're in my office because it hasn't gone away, and then we talk about what the treatment options are for that, okay? If I can go to the next slide. I'm trying to click my button, it's not working. So it happens more commonly in women. We can see the peak age here, 40 to 60. About 3% of people will have this throughout their lifetime. It's more common in diabetics. Diabetics actually probably have a different process to get a trigger finger than what I was just describing. Because sometimes it just happens and we don't even know why. Okay, it's not always because you went out and you chopped a quarter wood with your axe in the backyard. It's other things sometimes as well. And then the ring finger is the most commonly involved finger, which everyone says, I wonder why that is, right? Well, when we look at the ring finger, it actually has, of these metacarpal bones, where the little pulley that I was talking about, that little tunnel, attaches to the bone, it overall is the thinnest of all those bones. And because of that, it has the smallest tunnel. And so the smallest tunnel is probably why the tendon rubs on it more, right? So kind of interesting, huh? So you'd think, your small finger is going to have the smallest one, but look at how big that one is compared to the other ones. Kind of interesting when you look at x-rays. And I look at them all day, so I see all kinds of funny things. But all right, let's go to the next slide here. Far away. Okay, so it's kind of what we just talked about there. The pulley can actually get 2 to 3 times thicker than it was before, which is kind of crazy. Sometimes when I'm doing surgery on these, it feels like I use my knife, it's 1 swipe, 2 swipes, you be very gentle, but on the 8th swipe, you're like, holy cow, this one's a thick one, Or they'll make kind of almost a crunchy noise when you're going through, which maybe that's gross to tell you about, but I mean, it's pretty amazing our human bodies, how they adapt to these things. So other things that can cause, we talked about the diabetes, rheumatoid arthritis, gout, anything that causes inflammation in your body can also cause issues with this. Am I standing right here? Probably not. Okay. Just realized. Okay. So we talked about that pulley. Here's a little a drawing of all the pulleys that there are in a finger. So there's a lot of stuff, right? In medical school, when I went to Ohio State, we went to our anatomy lab. And we do our gross anatomy, we dissect the cadaver and that sort of thing. It's kind of interesting, right? On the hand day, they said, these are the hands, there's tendons in them, here you go, right? And so it takes a long time. We talked about hands, how complex they are. Just understanding what all these little things do. I had somebody in here, who was it, who was telling me they were rock climbing. Okay, rock climbing, right? So we talk about rock climbing, having to have a grip on there. There are certain pulleys on here that are really important for rock climbers. Those don't include the ones that cause trigger finger. So oftentimes, if we have to release a trigger finger for someone who's like a rock climber or something, who someone needs a really strong, grip with the tips of their fingers on there, we can release multiples of these and actually be okay. All right? Rock climber gets other injuries though when they fall and grab on and stuff. Well, more than the fingers too, right? Yeah, so understanding that pulley that causes this is this one right here, called the A1 pulley right here. You can see it's right over the top of the joint, right over the top of the knuckle. So me as the doc, when you come in and we're examining it, it's pretty easy to find your knuckle, right? You just look, oh there it is, and then on the other side, that's right where your A1 pulley is. So I can push there often. If you push on your knuckle right there and it's tender, and you keep your thumb there, and you move your finger, often you can feel the nodule in the tendon passing through that little pulley. It's like a lump that you can feel in your tendon. And if your finger is locking or catching, you can actually feel it do that too. You can feel the locking occur. So if you come to the office and we're examining you, that's what I'd say. Oh, I can feel the nodule in there. Look, it's locking, and then we can say, yes, you have a trigger finger. Okay, so it's often just a clinical diagnosis. You tell me, doc, when I wake up in the morning, my finger's stuck down, I have to grab it, it pops, it hurts when I extend my finger out, and then from there we go a longer discussion. Okay, so what do we usually do for this? What's the treatment? The first stop usually is trying to treat it conservatively, okay? So not surgery right away, but usually a steroid injection. And the steroid injection is meant to decrease the swelling that occurs in that pulley and in the tendon itself so that it doesn't get caught as it's going through that tunnel anymore, okay? And do they hurt? Of course, right? Steroid injection into the palm of your hand, it's going to be sore. I try to do everything I can to make it not hurt, but that's always the question, doc, is this going to hurt? Yeah, unfortunately it will. It'll hurt. I usually tell people it hurts for 2 or 3 seconds while I'm putting the medicine in. The needle doesn't hurt too bad because I numb up your hand with some spray, and so I get the needle in there, but it's actual medicine kind of stings and burns as it goes in there. Okay? Haven't had anyone pass out yet though, so knock on wood, okay? Here's the other thing there. Steroid takes a couple days to really start working. And then if you've had your trigger finger for more than 6 months, sometimes the probability that the steroid shot will make you all better. And that's the other thing I should tell you. The steroid shot can be curative. In about 2/3 of people, I give you 1 shot, it will never come back. Okay? If I give you a second shot, an additional 2/3 of people will get all the way better. So the odds are about 88% that you will get better with a shot and never have to have surgery on that finger. Okay, so it's actually pretty good. Beyond that other 12%, and there's some other factors that kind of will lower that percentage for you. But that other 12%, that's when we start talking about doing something surgical to fix it once and for all. Okay. So what do? If you're in the 12%, we talk about a surgery. And the surgery involves going in and actually cutting through that little sheet, that A1 pulley that's there. Okay, so we have lots of little pictures that show the same thing. But there's the pulley with the nodule, the swollen portion. Here it is with it open. Now notice, right, I kept the A2 pulley, the C1 pulley, the cruciate pulley, A3, all these other ones are intact. I just have to cut the one 99% of the time. Okay, there's always the outliers who have other things going on where you have to kind of go further, but that's probably too in-depth to talk about. Okay? And that's only people who don't get better with their shot, obviously. So there's a lot of different ways to do this. Somebody said, what if you get it in your thumb? Well, it's called a trigger thumb, just like that says. You make a little bit different incision for that than some of these other ones. The traditional way to do this is either longitudinal, this kind of dart-looking incision, or something horizontal. So you have a little, half-inch incision, a couple stitches, that sort of thing on your hand. And traditionally, I do it this kind of like this. My view is that you've got nerves and arteries that run in that same direction. As long as you're not cutting across them, that's usually a better thing. So I go with them, so into those. Okay? People will do it percutaneously, kind of blind. They take a needle, they just stick it in there, and they drag it across. I'm not one who likes to do things without seeing what's underneath, or my knife is, or my sharp thing is. And so I like to see what I'm doing. And so I don't necessarily do that. But just like we talked about, the ultrasound is kind of why we're here to talk about doing it that way. Okay? So usually when we're doing an open carpal tunnel release, or trigger finger release, Freudian slip there, it's usually about 6 weeks until it's not tender anymore over that incision. Even though it's a tiny little incision, I have to go through a couple layers of tissue to get down to that pulley and make you sore. Often as hand surgeons, we're kind of amazed at how sore people can get from this little tiny incision. Okay? But very few people will need hand therapy after that surgery. Usually we can teach you how to do your own scar massage, you can use your hand, that sort of thing, to get it back to feel better. Okay? Now here's kind of the new directions that we're talking about here. Okay? So this is a little picture of
what an ultrasound would look like of your finger. This is looking at the axial view of the tendon as it's going across the bone. Okay, so the bone is down here going in and out of the screen along with the tendon that's in and out of the screen. I can see your arteries. I can see the nerves as I'm doing that. I can see the A1 pulley. We call this the Mona Lisa view, which I always thought was kind of funny because it kind of looks like Mona Lisa here with her head. Here's her hair right there. You see that? So when we get to the Mona Lisa view, that's when we know we're in the right spot with this trigger finger, A1 pulley. Okay? And we use the ultrasound so we can see everything. Just like I said, I don't like doing blind stuff. I like being able to see so we don't hurt people. There's an incision. Okay, I grabbed this from the website. That's what the incision looks like. I mean, we've done enough of these now here in Prescott. I mean, it's no bigger than this little tiny thing there. Okay, so it's small enough that we don't have to do stitches. I usually put little steri strips over the top of it, put a little piece of gauze, a piece of Coban around that, a little kind of that sticky bandage stuff. That wrap, right? You keep that out for a day, and you put a Band-Aid over it, and you're good to go. So it usually heals you up pretty quick. Okay, so we usually use a local anesthetic for that. I feel like this is going in and out.
It's finicky.
Is it?
Yeah.
Okay. I'm trying to keep it right in the same spot. I'm not doing a good job. But we usually use a local anesthetic. So that burns a little bit when we get it in, but it makes you nice and numb. I guarantee you it's better to have the local anesthesia than to not. Okay? Meaning if we did it with no anesthesia in your hand, it would probably hurt. So that's why we do the local. Okay? And I've not had a patient ask for narcotics afterwards. We usually just say take some Tylenol or some ibuprofen and you're good. Okay? Yeah, and then the biggest thing is, instead of that 6 weeks, back golfing in a few days usually afterwards. I've had one patient who's had kind of some lasting tenderness over the area, but it's not related to the incision or anything like that. It's probably more related to the inflammation that was there beforehand, is kind of what we're thinking. Their finger is cured, it doesn't lock or catch anymore, but it was a little bit tender for a few weeks afterwards. But it wouldn't have precluded that patient from going and using their hand to do yard work or go into the golf range or play pickleball. There we go. That's the little gizmo, the device that we use for this. You can see the way this works is there's a little skid along the end of it. So the incision is made, obviously this isn't life-size, okay? This isn't what I use, anything like this. But that's the size of that little tiny incision. So we make the little incision and slide this skid in. This is kind of the switch on the end, and then the knife you can see is right here. I don't know if you can see that, but it's right there. It's got a little hook on the end of it. And so you slide it sideways down underneath the pulley, under the ultrasound, flip it up like this, and then pull it back. And the knife is only this little kind of shepherd's crook portion of this, and it grabs onto the pulley and divides the pulley as we come back. So I don't have to cut through the skin over the top of the pulley, and then the fat, and then the fascia, and then all the way down to the pulley to do this. So there's less tissue that is injured as I do it, hence why your recovery would be faster. Sure. Yeah, so his question is this the standard treatment now? I wouldn't go that far yet as to say that. It probably will become one of the standards. The saying, there's a lot of ways to skin a cat, right? The kind of the tried and true way of doing it is probably still the open trigger finger release. There are a lot of people, in fact, the whole reason we're doing this today, because this is a new technology. It's a new way of doing this. And just to get the word out so that people know that there are other ways to do it other than just the open trigger finger. I've probably, yes.
This works only with the ultrasound.
Yes, I would not use this without an ultrasound. Yeah, for sure. His question was, do you have to use the ultrasound? This only works with the aid of an ultrasound. And yes.
In the diagram, you showed this one incision in the back.
Yes.
joint dependent? Will that move, i.e. if it's the index finger move? Towards that?
Exactly, yeah.
So
The incision is made over the top of the tendon that goes to that finger. Correct. Yeah, so you move it across the hand. Yeah, go ahead.
This is new, what is that called?
The Ultra-guide trigger finger release. Ultra-guide. They printed the name on there, and then that's the company that makes it. Marketing, right? Yeah, so that's what we'll use for this, and I'll show you kind of a little picture here. So again, back to this drawing that we looked at before, there's that little pulley that we're interested in. Some people have something called an A0 pulley, which is not common, but some do have that, which will be addressed along with this A1 pulley. The A1 pulley is kind of the bad actor in the whole thing, and that's the one that we divide. So that's the ultrasound picture. Didn't really come out as clear as they normally look, but you can see this little area up here. That's where we can see your tendon. Okay, so that's the tendon there. This little band that's right here is this palmar plate, kind of that light blue thing that goes over the top. And then the pulley, we can often see as a thickening as it goes over the top here. So right here on top of where this kind of stranded view is, we can actually see the two tendons that are right here, the FBP and FBS tendons, and then the pulley is right here. There's the A1 pulley right over the top of that. We can actually see that on the. Oh, sorry. Yeah. What was the question? Did anyone have a question? Sure.
I wish you could just complete that slide if you wanted to.
oh, okay.
Sure. Yeah, absolutely. And so this is someone using the ultrasound in the palm to be able to see that view, and then we would slide the machine in, that little instrument I was using. You can actually see it coming underneath there, and we watch it go underneath the pulley to make sure that it's in the correct place, that we pushed it in far enough, that it's not too far, and then we turn the view, like that view that we looked at before, which was the axial view, and make sure it's right on top of Mona Lisa's head, okay? And then that's when we go ahead and pull the neck out. Go ahead. That's a really good question. So her question was, with this new technology, do we know if insurance is actually covering it? They are covering the surgery itself. They don't pay for the instrument itself. Yes. Okay, so that's in as it goes along. So the way things work in the medical field is that there has to be so many of them done, and then you submit that into the insurance company and say, hey, look, we're doing this procedure, will you pay for it? And you have to actually individually kind of go to all the different insurance companies, and how many insurance companies are there now, and then tell them about it, and then usually they will approve it going along. Once things have been going on for many years and it becomes kind of the standard, like he was asking, then it's a no question, no brainer, right? Oh yeah, we'll cover that. So, but right now, not so. Yeah. The procedure. Yes. That's right. That's right. Yep. Absolutely. Absolutely. Absolutely it is. Yeah. And we have a very open and frank discussion about that beforehand, right? We talk about the numbers and like, this is what this is how much it costs, and if you want to pursue it, that's fine. Some people have insurance plans that cover everything, right? And so they say, well, I don't want to pay anything, and that's perfectly fine. I mean, all you're selecting is that, you're not going to be golfing in 2 days afterwards. That's not the difference really in the end. So. It's a similar type of tissue, but it is different. It is more like a ligament than a tendon. So there's probably more elastin, or there's less elastin fibers in it. It's more of a fibrous, kind of a harder tissue. It's meant to be more like a rope than a bungee cord type of thing. And tendons, while they also are kind of like ropes, they have a little bit more elasticity to them than
You say divine.
Yeah, yeah,
Cut the pulley is no longer effective as a hook.
correct. But it grows back together. Yeah. So his question is, when I cut the pulley, then it's no longer a pulley, right? It's divided. And my answer is yes, until it grows back together. But it grows back together at a larger volume, so now it's not catching on the tendon anymore as the tendon glides through there. Okay, so essentially we're creating a bigger pulley that won't cause the same problem.
Compared that blood supply, it takes a long time to go back.
No, I would say about 6 weeks. Yeah. Oh my goodness, okay. Let's start over here and then we'll keep moving over. Sure. The injection, yeah. To give you the shot, no. You don't need to go into the tendon to give the shot. There's actually a lot of good. So her question is, she's had the shots before for a trigger finger, and her question is, do I go into the tendon? There's actually very good literature now that says that you go on top of the tendon. Because when you go into the tendon sheath, it feels like your fingers can explode, doesn't it? And it hurts. Okay, good. To go to sleep for it? Yeah. Are you? Her question is, do you have to go to sleep or can you be awake for the surgery essentially? Yeah, either way. I usually don't put people to sleep just because of, I mean, we're talking about costs and that sort of thing, right? It's significantly more expensive to have general anesthesia for a 2-minute surgery than it is to just go ahead and do it. But those people, I have a certain patient population that will have pain issues with the surgery, or meaning that they don't want to have any pain, or number two, that have anxiety issues or questions about being awake as we're doing a surgery, right? And so that patient population, yeah, we accommodate, or usually it's just some sedation. We'll go to the surgery center, have the anesthesiologist give you some sedation while I give you the injection, and then as you're waking up, you're done. Yeah, absolutely. What other questions I have? Yes, sir. VA, I see VA all day long. All day long, absolutely. Yes.
So what's the effectiveness of the injections? It's been going on for 6 months.
So longer than 6 months? So her question is, what is the effectiveness of the injection if it's longer than 6 months, right?
If the trigger finger
Yeah.
is going on for
Longer than that. I usually tell people that the data doesn't include that very well in our scientific literature, but it probably changes from 2/3. So I usually, what I'll do is I'll give you a little handout in the office and I say, 66% of people get better with 1 shot. The other 33% of people, if I give them a second shot, 2/3 of them get better. So that's 22% more. So you add that back in, that's 88% total, 66 plus 22. That leaves 12% of them get all the way better. Those numbers change to 50% of people get better, and then 50% don't. And it's the same for my diabetics too. And then so it's 75% total with the second shot, so 25% end up needing to have surgery if it's more than 6 months usually. Yeah. So it just changes your numbers a little bit. Did you have a question?
Yeah.
Yes, go ahead.
I'm showing some signs of like thickening in that same region, and my mom is having it, so I'm
Okay.
assuming that's genetic. I'm wondering, is there anything I can do to prevent before it starts to do? I haven't had any sign of that, but I'm thinking that.
So
Her question.
I wish this one.
Her question is about
Genetics.
genetics. Genetics.
Genetics. Doesn't make that difference. Yeah, maybe better.
Genetics related to trigger finger. There's probably some component of genetics in this. That's probably not delineated very well. There's some other conditions with thickening of fingers that one of our audience members had. That's called Dupuytren's disease, and that very well may be more likely what she's talking about. Trigger finger and Dupuytren's disease are different, but often confused with each other. Because Dupuytren's disease is a disease of the tissue, the fascia, that is over the top of the tendon and above the layer of where the pulley is. Okay, so it's a different tissue that's having the problem. And that often causes static contractures. Have you ever gone to shake somebody's hand and their pinky finger's in the way? Has that happened to you before? And you say, what in the world is that? Well, that person probably has Dupuytren's disease, and it has pulled their finger down and they can't straighten it out anymore. Okay, so that causes thickening of the palm. And that is very strongly genetic. Trigger finger in and of itself probably doesn't have as high of a genetic component, but it certainly is feasible. I mean, we're finding more and more osteoarthritis in people's hands, genetic, right? Dupuytren's, like I said. Diabetes, right? You have a propensity to have diabetes if your parents have diabetes. So there's a lot of things that there's a large genetic component to it. Now, how do you prevent that? That's really the question. So with a trigger finger, the problem is swelling in that tendon. So anything you're doing that could cause swelling, you try to minimize that, right? So when I talk to people about when they're outside working in the yard, wear some gloves. Go to Home Depot, buy $20 gloves and have padding in them that pads right over the top of where we get these trigger fingers, okay? Because that's going to stop that irritation from happening. Other things, I mean, that's really all I got, you know. You try to think of, I've had people hiking, right? They, on their hiking poles, put some extra padding on the hiking pole so it doesn't irritate your fingers. Try to avoid activities maybe to where you are, you know, constantly, consistently, you know, making fists or something like that. With pickleball, try to wear a glove or pad up your handle more. There's something, I have another lecture here that we can talk about real quick, maybe if we have time too, which one of the recommendations is to, when you're holding your pickleball paddle, hold it looser. Don't try to strangulate that paddle when you're holding it. So things like that would decrease the amount of swelling that you have. Who else? Okay. Okay. Sure. Yeah. Yeah. She's on oxygen, and when she's out, she tries to get around, has to push her oxygen tank around. I think what you did is absolutely wonderful. You put a big pad on there, didn't you? Yeah, and taped it on there. Okay. Right. Yeah. So most of the time, so her question is, what she's saying is that she goes to therapy for a trigger finger. Therapy in and of itself is probably not going to be tremendously helpful for a trigger finger. At least that's what our scientific literature has said. And if you think about it, what are the advantages of therapy? And there are basically three in my mind. Number one would be range of motion. They can help you get your range of motion back, right? Well, as we're ranging our hand, we're actually making that tendon go back and forth through pulling more and more and more. That probably is irritating it more than helping it. Number two would be strengthening, right? Therapists are very good at teaching you how to strengthen certain muscles. That's not really going to be an advantage here either, strengthening that finger, because it's not necessarily a strength problem, it's a more mechanics problem. And then number three, they could do like massage, ultrasound, TENS unit, those sorts of things. And that, again, hasn't really borne out to be significantly helpful for a trigger finger. Now, she said she had an injection and it's been 2 weeks and it's still triggering. That is not uncommon. I tell people when I give you a shot, we're gonna wait 6 weeks before we decide whether or not the shot worked. So 2 weeks, you're still kind of, and what I usually tell people is I say, the day that you think the shot didn't work, when you wake up the next day, it's usually gone. And I don't know why that is, but people have this like, you know, epiphany. They say, man, that doc who gave me a shot, he said it would work. He's full of baloney, right? And then they wake up the next day and go, oh, it's gone. So, I don't know. A brace for your trigger finger? Okay. So braces have kind of gone out of style at this point for trigger fingers. That was a big push by the Mayo Clinic. They actually had their own brace that they made that they would give to people or sell to people. Those, again, our literature has shown that they're probably not helpful. Same with taping the fingers and other other things that we do to stop the triggering. I get it, right? When you wake up in the middle of the night, your finger's stuck down and it hurts. You think, well, I could do something to make this not hurt, right? And so you try taping it or a brace or whatnot. That sometimes can make it not trigger, but it doesn't make your trigger finger go away. Does that make sense?
So I should just, they said, try to avoid the triggering at all costs, so
Yeah. Right, regardless, yeah. No, she says they told her to try and avoid the triggering at all costs. And I say live your life. We have ways to fix this, so, yeah.
And is it very fast?
Is it fast, the surgery?
No, she's fast.
Oh, vascular. It can be, but usually not at all. Usually not at all. The numbing medicine that we give you has epinephrine in it, and so the epinephrine actually helps your blood vessels to clamp down, and so you don't bleed necessarily when we do this. I never have anyone stop blood thinners when we do these surgeries. Heaven forbid you had a stroke because you had a trigger finger. You know, that's silly. Let's go here and then here.
Hi, I had trigger thumb release done 4 or 5 years ago, and I believe I had some nerve damage because of it.
Okay.
Is there anything you can do about that?
Yeah, so her question is, she said she had a trigger thumb release a few years ago and has some nerve damage because of it. So the thumb is notorious. There are the neurovascular bundles where the nerves and the blood vessels are run right over the top of your thumb pulley. And so they are very close by to where we're operating. We don't do this surgery with the ultrasound on the thumb because of that reason. That almost has to be, at this point at least, we're kind of figuring out ways to do it in the future maybe, but at this point we don't do it with the little instrument that I showed you because of that reason. So your surgeon, her job is to find that nerve, move it out of the way, and cut through that pulley. If it gets damaged, let's say one of the retractors pulled on it or something like that, or a knife hit it, I don't know. There are things that can be done. It's often kind of a, swinging for the fences type of thing, where we would have to go and find the neuroma or where the nerve was injured, cut out the injured portion, and then put a cadaver nerve in between the two ends there. Usually you will get some sensation back. It will never be normal regardless, and this depends on how bad the injury is. If it was cut all the way through versus a bruise, bruises often will recover. Cuts in the nerve, obviously, when two ends are not together, it's like, can I cut this extension cord and make it work, just by having them 6 inches apart? Yeah, no, that doesn't work. So you gotta connect with that. So, but we could look at it, we could always look at it and talk about it. Just depends.
Okay, thank you.
Now you had a question, and then we'll go to the other ones. Yes, sir. If you call my office to make an appointment, what's the timeline? Let me just say this before anyone calls our office, okay? You're certainly welcome to call our office. We are working on our phones, okay? I apologize beforehand. We're working on our phones at this point, okay? But usually what will happen is, it depends on your insurance, but if you call and say, I want to make an appointment, they'll often ask, what is your insurance? If you have Medicare, straight Medicare, usually you can make your own appointment. You don't need a referral, okay? The problem is when you need a referral. If you have a Medicare replacement plan, if you have other kind of insurance that requires a referral, you have an HMO and not a PPO. So there's all these silly things that go into it, and it's sometimes hard to just give you a straight up answer. If you call, you're gonna get it this quickly. Often my clinic for things like trigger fingers runs probably 3 or 4 weeks out, okay? We try to get people in. The problem is we have to reserve some spots for when you're playing pickleball and you trip and break your wrist. I can't see you 4 weeks after you break your wrist. I need to see you right away to be able to advise you on what we need to do for that. And so that kind of bogs things down. It's funny because, as the doc, I certainly want to see and help as many people as I possibly can. But, through the day, we normally see 40 to 45 people, and that's cramming everyone in and trying to see to see everyone and give them the time that they need to be able to be seen. And even doing that and having, we have 2 PAs, a nurse practitioner, see people, it delays how many people we can see and when. It's usually, it can be 2 appointments, or it can just be 1, but remember, usually in the first visit, I'm gonna say, yeah, you have the trigger finger, let's give you a shot. So you get a shot that first time. And then my line is always, make an appointment for 6 weeks. If your finger is better, cancel the appointment, I don't need to see you if you're better. And so that does free up some other people. So it's usually just 1 appointment, honestly. Yeah. What's my remedy for Dupuytren's? So Dupuytren's disease is a totally different topic, right? It's the genetic thing that we were talking about. There are multiple different treatments. It depends how bad it is. My first remedy would be if it doesn't cause you functional change in your hand, if you can do all the things you can do, my first question is going to be is, what can you not do because of your Dupuytren's disease? And if you say, nothing, I can do whatever I want, the answer is we don't do anything. If it becomes a functional problem where, doc, I can't put my hand in my pocket anymore, I couldn't put my hand in a glove anymore, I can't hold my golf club. I had one gentleman who said every time I put my glasses on, my finger pokes me right in the eyeball, okay? Those people, then we start to talk about treatment, and the treatment is to straighten your finger out. And how do we do that? Depends on where your cords are. Oftentimes, we'll do an in-office procedure where I can just numb up that area and poke it with a needle, poke a little cord with a needle, and then straighten your finger out. That works in most people. If it's a little bit more severe disease, then we talk about actually going into surgery and making a big incision. There's some other medications, injections called Xiaflex that people will use. I have some ethical concerns about Xiaflex that I can talk to you about if you wanted, but I don't want to badmouth anyone's product, but there's some issues with that I don't necessarily see eye to eye with them, so I don't use that product. But that's usually the way that you do it, is those are the kind of options for Dupuytren's disease. We'll go here and then right here. Yes, sir. Low finger bait splint. It depends. It can, yeah. Like if you have a mallet finger or something like that, a trigger finger. I mean, again, we go back to what are we doing with that, right? It might be helpful to wear something like that. Is it going to change the overall process of what's happening in your finger? Probably not. Yeah, it's not going to make it go away. Yeah. Here, and then over there. Yeah. Yeah. Dupuytren's disease? Yeah. 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 So you're asking, is Dupuytren's disease and trigger fingers? Yeah. No, that's a little bit more complex probably. You may have some sort of connective going on if all of the fingers are triggered. Absolutely. But that is not Dupuytren's disease. Dupuytren's disease would be something totally different with the fascia and not the connective. So connective tissue is a very general term. Any ligament, any tendon, any joint capsule, all your soft tissue basically is connective tissue. So the biggest connective tissue disorders that we talk about are like Ehlers-Danlos and Marfan syndrome. Those can have other issues beyond, right, like blood vessels and that kind of stuff. Diagnosed. That's usually a genetic test. They usually do a genetic test. I would send you to a geneticist. We would be able to see signs and symptoms of it in the office and say, well, you may fall in this category. Let's go get have you see somebody who's an expert in this field and have you get that diagnosis. Yeah. Now, what was the other one? Yes. Yes. Sure. starting to lock. So she's avoiding using her thumb, and the index finger is starting to click. You certainly can. I mean, you know, my line that I think is funny, I don't know what you think is funny, is that thumb and the index finger are connected to the same hand, which are connected to the same body, right? And they've had the same number of birthdays, and they've been through the same number of stuff. So certainly, right? Certainly, you can get it in other fingers. The thumb is number 2 on the list of most common. So it's ring finger first, thumb is number 2, is the most common. That we get it certainly.
I've had the 2 cortisone shots. With this technology, what is the success rate of opening the tunnel? I mean, try to shrink the police size.
Sure. Yes. Yeah. If we cut your tunnel and open it up, 100%. Right? The question is, did you miss the tunnel? Did you get all of this? Right? So that's really the question. And so you'd have to go back, and there's probably not enough literature yet to know how often do we miss the full tunnel. Right? Yeah. So the cortisone didn't do that for you? No. Yeah. Well, the steroid takes 48 hours to do anything. So whatever the lidocaine or the lubrication, you know what I mean, maybe you stretched out the pulley or something, you know, there's probably something else that did it, but the lasting is the steroid when it causes that stuff. Okay. Still doing it? Yeah. Yes, sir.
I'm sure you've noticed a few silver hairs.
Right.
Here. Does Medicare cover this new procedure?
They cover the procedure, they don't cover the instrument that we use to do it. Yeah. So then, and again, right, we're working to get that so that it would be covered. It's just not yet. So, yes. Sure. Yeah. This question is steroid and tendon weakening, right? You may have heard about that before, and that's real. That's why we give you 2 shots, no more. That's why we space it on 6 weeks. So over time, if you were to have multiple injections, so let's say, you know, we've had 2 shots, and it's 8 weeks after our second shot, and doc, I gotta go to, how many times I hear this in my office? It's awesome. Hear about everybody's vacation. Doc, I'm going to Croatia. I planned this with my wife for 3 years. It got delayed because of COVID. It got delayed because of this and that. So what? You have to go. Can't you just give me another shot and my finger can feel good for my Croatia trip, and then we can come back? You know, I'm a reasonable guy. I probably would say sure. But you are at a higher risk as we continue beyond the standard 2 shots. If I give you your 3rd, 4th, 5th, 6th, 7th shot of rupturing a tendon, which is a bad day. That's a bad day for you, that's a bad day for me, because then we're talking about having to repair a degenerative tendon. Sometimes we have to take a tendon from somewhere else and transfer it there. I mean, it's a big deal. It's, you know, 4 months of hand therapy, so we try to avoid it. 2 shots doesn't cause enough weakening to cause any issues. Now, if you were someone who took oral steroids for something else, and then, you know, maybe you're frail because you have rheumatoid arthritis or something like that, you've got other conditions, I would definitely tell that person no more than 2. But even with the 2, I'd say maybe we should consider doing something other than this. But that's just, it's a case by, that's why medicine, I can't ever say yes 100% you're going to be fine, because everybody's so different, right? We all have different conditions, we have different genetics, we have different health problems going on. So that's why we talk. A trigger point release? Tell me more what that question is about. Oh, like a musculoskeletal thing? Yeah. Different from this. No. You know, trigger point is a debatable thing. That's kind of more of a physical therapy thing more than a medicine thing. Yeah. Yes, ma'am.
Like from a patient's point of view, if I'm thinking I probably am more of a Dupuytren person, and my mom is probably having it, right?
Yeah.
What's the difference? I don't know what a trigger finger is then.
Sure.
What are the differences?
So Dupuytren's disease, boy, I should have got that out. So like if we look at this picture, the trigger finger is caused by that pulley right there going over the top of the tendon, being too narrow for the tendon to pass through there. So it is a dynamic process. As your tendon passes through the pulley, it will lock, catch, pop, click, whatever onomatopoeia you want to use to do that, right? It's our word of the day. Whereas Dupuytren's disease is actually in a layer of tissue that is above all of this, called your palmar fascia. It happens mostly in the palm and not the fingers. This is a drawing of a finger. This is the finger. This is where the palm actually starts right here. So you would see a thickening of this normalized tissue. It's a normal tissue that has a genetic defect in it. I guess, I don't know if that's a politically correct way to say it, but it thickens that tissue and makes it actually pull the finger down in a static manner. So you're no longer moving past that. It stops you here, or it stops you there. You can go down, but you can't straighten out anymore. Yeah.
And then is trigger finger painful? And
Yes.
is Dupuytren's painful?
Not painful. Dupuytren's is not painful. Yes. Yeah. 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 Steroids or anything. So her question is there any medications, any topical? I mean, the answer is always, you could always try those. In our scientific literature, none of that has proven to change the outcome of your treatment. So our two options are really, and if you come into my office, our two options are really, well, there's three options, right? You can just say, I don't care if my finger never works right. I'm going to ignore it for the rest of my life. Okay, that's option one. But you already came to the office, so you probably are not thinking that. Number two is the injection, and number three is the steroid. We have to change the mechanics of how that finger is working in order to make it go well. And the creams and that sort of stuff don't do that.
Once the finger is locked,
Yeah.
and it's not still triggering.
Sure.
It's
It's
locked.
kind of stuck down. Is that what you're asking?
Well, for me, it's my house.
Yeah, so your thumb is like this. It's locked straight,
Well, I can go down,
but you can't go all the way straight.
no, no.
Okay.
I used to because
Sure.
it used to go back.
Okay, hyperextend.
Yeah.
Yeah, doesn't do that anymore. Sure. It is. It is. Yeah, but again, a thumb, we don't use this instrument for the thumb. But yeah. Yeah, it's the same surgery where I would go in and divide. On your thumb, you have an A1, and then the rest of the pulleys are a little bit different. You have an oblique pulley that goes across. There's an A2 as well, but it's kind of a different thing just because it's not as long. Yeah, about until, I say 6 weeks until you, like, say, which thumb is that? Oh, yeah. That's kind of 6 weeks till you're all that. It takes the swelling out of the tendon. So that swollen nodule that you have in there shrinks it down again, and it stops that pulley from being narrowed. So it takes any of the swelling out of there. That's the idea. Yes, sir.
History, you recommend surgery. And I've had both of those, thickenings for years,
Yeah.
but it hasn't affected the finger.
So we're talking about Dupuytren's again? Dupuytren's disease?
They told me the truth.
Oh, did they? If there's thickening in your skin, that's most likely Dupuytren's disease. If it's getting caught as it goes down and popping as it straightens out, then that's a trigger finger. So if it's Dupuytren's disease, just like we were talking about over here, you have to tell me, I can't put my hand in my pocket anymore, I can't put my hand in a glove anymore because my finger doesn't go straight. So if it's stuck. Yeah. Yes, sir.
So, my question is that the pulley obviously keeps the tendon in track.
It does, yeah.
So if it's provided,
Uh-huh.
now is that tendon going to be slipping off the?
So you remember that picture that I showed with all the different pulleys on the finger. So you can actually divide probably about half of those. Other ones keep it in track. Yep. But back to rock climbing, if we get 2 of those, and that's what happens. We call it just a pulley avulsion, basically. If you fall down and it rips one of these big pulleys, it'll often rip half of them out of there, and you get bowstringing, where you go like this and you would see that tendon popping out, and it loses the efficiency in how your finger is grasping. And so that's a problem, right? If you're a professional rock climber and you don't have your ring finger working correctly, you're done, right? You can't rock climb anymore. You're not going to do free solo. Anybody watch that show? The free solo show about the guy? Yeah, incredible. But I mean,
So you're more risk of doing that if you divide that A1?
possibly, but I would say probably not. Probably not, because it will heal back in. But I wouldn't let you rock climb for at least 6 weeks. Probably about 3 weeks before I'd say go rock climb. So the pulley is up. What else? What are we time-wise here?
Yeah, let's do one more poll of how they heard about this, because we've had twice as many people come in since the original poll.
What were our poll? So let's ask, we want to know how did you hear about this event? So raise your hand again if it was newspaper. Okay. Raise your hand if it was the Espire forum out there.
It was an email.
Or an email, yeah. The Aspire email, Aspire contact, I guess. And then raise your hand if it was on Facebook or social media. You good? Yes, ma'am.
Online.
And online, yes, that's right. That's right. You had it on.
Good presentation.
All right, thank you. Yes, sir. One more question. Yeah.
If the steroid injection takes their inflammation down,
Yes.
why can't you just immobilize it for a while to keep the inflammation down so you're not constantly...
Really good question. I don't know. The answer is that for whatever reason, when they have done the research and done scientific studies on that, the immobilization doesn't work, because that's a great question. I often will tell people when they come in for their basal joint arthritis, right? Their arthritis at the base of the thumb, which is a totally different discussion than we've had here. What are the 3 things we do? Take an anti-inflammatory, wear a brace, and have a steroid injection. Why would we do that? Because it decreases the inflammation. For whatever reason, that doesn't seem to change the natural history of this problem. Maybe it's because there's not enough decrease in the inflammation by immobilizing it, but that's a very good point.
Now, I had trigger thumb in this hand, and I was a gymnast for 25 years, so my hands are pretty good.
Sure.
So I went to my orthopedic. I said, all right, doc, what do we do? Injection or surgery? I'm like, I went right to my physical therapist. We made a brace. Went around here,
Yeah.
strapped over, kept my thumb straight. Not straight, but I had it bent to a certain way. For 2 weeks.
It went away. So you probably fall into the category of the same person who I never see in my office, because theirs just went away. Like at the very beginning of the presentation, we said there is a certain percentage of people, I don't know who it is, who have a trigger finger because they weed whacked the whole yard and their finger was locking on them, and it just goes away. So most likely, and I don't know for every scenario, most likely that would have gone away regardless. Maybe you were, and of course, right, in our scientific studies, there are some people who the brace would be helpful for. Now, who are those people? We don't know, right? There's a certain percentage though, just like there's going to be a certain percentage, and I'm not trying to equate these, but there's a certain percentage of people who, with their headache, they can eat a gummy bear and their headache goes away, right? There's just things that happen sometimes that don't follow the science that we say. Okay, different topic, but yeah. So right, there probably are some that a brace would be helpful for. Who are those people? Is it the majority of people? Our literature at this point says no. It's not the majority of people.
You want my name for your notebook?
Yeah, right. So this guy said that you can do this if you're a gymnast.
I could bring the brace and show you.
There you go. Yeah. Anyway. All right. What else? So back here in the back, if you want, we've got 2 ultrasound machines, and we can play around on the ultrasound machines if you want to. We can ultrasound your hand and kind of look at things, look at different structures in your hand, if you want to do that. I think you probably have, maybe about 30 minutes or so to do that. Make sure you eat some food too. We need to say thank you to Jennifer Booth for bringing the food out. She's our marketing person for Granite.